Yeah, sorry. Okay, so the second case, again, fairly recent patient. So 59-year-old male, he's an ex-smoker, he's got hypertension, and this time, this is an acute presentation, so he woke with severe chest pain radiating down his left arm. He had had some antecedent angina. He had described 3 clear episodes of chest pain on exertion in the lead up to that, and also some further episodes at rest in the week before this kind of acute presentation. This time round, the pain had lasted for 3 hours, and he'd eventually sought medical attention, by which time the pain had settled down. His examination was unremarkable. There was some fairly minor anterior T-wave inversion on the ECG. He had a high sensitivity troponin I measurement. So you have to kind of divide by 1,000 to get to the old kind of value. So that's a value of 0.3 essentially. So it's a small troponin rise. Again, normal renal function. He wasn't anemic. He had an echocardiogram that showed some hypokinesis, some mild hypokinesis of the anterior wall, and overall mild left ventricular systolic dysfunction. So a diagnosis of a non-SC elevation myocardial infarction was made. And a decision was to perform an early angiogram. So these are the pictures. So you can see that he's got an occlusion of his LAD here on that view, and there is some late distal filling of the distal vessel from collaterals. He's got quite a tight lesion in his circumflex, just at the origin of the first obtuse marginal vessel. And again, he's got a tight lesion in his kind of proximal mid-right coronary artery of a fairly large dominant vessel, and that vessel appears to be filling the distal left anterior descending artery late. So he had a cardiac MRI scan to look for viability in that anterior wall, and you can see it's absolutely clean as a whistle, no evidence of myocardial infarction on that MRI scan. So showing we can't really identify an infarct with a troponin elevation of 0.3 on MRI.
This is a gadolinium scan?
These are the late gadolinium enhancement pictures. So infarct would appear white on that as a kind of subendocardial or transmural pattern. So no late enhancement. So that was the case. Patient admitted with a non-STEMI, 3-vessel disease, and the decision facing the operators was whether to discuss, well, it was discussed, but should the patient have a bypass operation? Should he have 3-vessel PCI, probably as a staged procedure? Could you consider a hybrid operation, or, again, should we go for medical therapy alone?
Well, thank you. Thank you very much. That's very clear. Very nice pictures. Thank you. Okay, Dr. Laufer, you're going to tell us the surgical case.
So thank you very much once again. I think this is a clear case for surgery because the patient is 59 years of age, has no left ventricular dysfunction, has no significant comorbidities, and he has a rather extensive coronary artery disease. Could you calculate the syntax score for this patient?
Well,
so, I'm not sure. Okay, so okay. Once again, the hospital. If we look now on the evidence, the available evidence in revascularization procedures in NSTEMI situations, usually, and this is confirmed by all the literature, the higher the risk of the patient, the earlier the revascularization should take place. It is not really decided if complete or a target lesion revascularization should take place at the initial as an initial procedure, and the relation which is observed in the general practice between PCI and CABG is about 80% to 20%. There are no randomized trials comparing PCI versus CABG in this particular setting of unstable angina, or in this particular case because of the troponin. I would say it's a typically, we can say that this is an NSTEMI. However, if these patients are stabilized by medical therapy, antiplatelet agents, as well as other medications, up to 30% of these patients are included in randomized trials of PCI versus CABG after stabilization. For example, the SynTax trial comprised about 28% of such patients. And for the surgeon, it's important to know that typically these patients are loaded with multiple drugs interfering with clot formation. So we are facing certainly an increased risk of bleeding, or at least we are facing, we need to face an increased attempt to substitute platelet function and give coagulation factors in this situation. So as we have no prospective randomized studies, there is an observational study, and as it has been done also in surgical cases, propensity score matched comparison was undertaken in the acuity study, and this is a subgroup analysis based on such a propensity matched cohort study reporting the 1-year outcome of NSTEMI stent versus CABG therapy, and you see there's a no significant but higher rate of death after 1 year. In the stent group, there is a cardiac higher rate of cardiac death, but not significant. There is a higher rate of myocardial infarction in the CABG group, but I want to remind you, by all these comparisons, these are a propensity score matching. We have a much higher rate of re-intervention as expected in the PCI group, and the MACE rate is also higher, borderline statistically significant. Whereas, as in all trials, we can observe that the cardiovascular accidents are higher in the bypass group. Now, if we have already said that this is a propensity score match trial, if we look on patients that get stabilized and then enter a trial like the SynTax trial, you will find this is, however, I have to say this is a complete cohort of patients with triple vessel disease plus or minus left main disease, and these are the 5-year results that have been reported. Also, it's not statistically significant. You see that the trend in favor of bypass surgery is there with a lower all-cause mortality, but not statistically significant at this particular point. If you look on freedom from death of any cause, freedom from stroke, and freedom from myocardial infarction, it is significant after 5 years. I showed you the SynTax study because there is another problem that arises with this type of trials, and this is the subgroup mania in the SynTax trials. There are several pre-specified and non-pre-specified subgroups that have been analyzed, and as you see here in this also 5-year survival group that separates different strata. And even if you look in the group of patients with the lower risk SynTax score and compare the outcome after 5 years of these subgroups with the patients that have been observed for 5 years in the registry of the SynTax trial, which was a registry that comprised patients who were too sick for, well, not too sick, but anatomically not suitable for PCI to be enrolled in the SynTax trial. So the very complex anatomical subset, the endpoint was lower in this high risk group than in the lowest subgroup of the SynTax trial. And that, I would say, casts a substantial doubt on the value of subgroup analysis. And I want to give you just here one depiction of the situation. This was published in the health technology assessment, and it says that subgroup-specific analyses are particularly unreliable and are affected by many factors. Subgroup analysis should always be based on formal tests of interaction, although even these should be interpreted with caution. And the results from any subgroup analysis should not be overinterpreted. Unless there is strong supporting evidence, they are best viewed as a hypothesis generation exercise. In particular, one should be wary of evidence suggesting that treatment is effective in one subgroup only. And especially if we want to prove that both interventions have equal quality and have the equal results, then one should be particularly cautious when interpreting subgroup analysis. Nevertheless, these subgroup analyses are going to make it for guidelines, and I think this is something which is not really in the interest of real good science. Now, why I'm showing you this subgroup analysis, because we don't have too much randomized data on this particular patient that was presented to us, and I have never, unfortunately, I'm not aware of any subgroup analysis of the syntax trial of patients that have been stabilized after initial phase of instability. Now, what is when we compare the outcome? Also for this particular patient, after 1 year, for example, what we also can learn from the syntax trial, that the adjunctive medical therapy is much less for the CABG group than in the PCI group. So I don't understand why do we have less antiplatelet medication, but we also have not only less antiplatelet medication, we have less statin therapy, for example, 75% versus 86% in the stent group. We have less beta blockers, we have less ACE inhibitors, and we have less calcium channel blockers. So I think there is room for improvement of surgical results if there is a more strict use of these adjunctive medications, and that would be also very important for our patient that was presented. Now, if we look on the antiplatelet therapy, does that matter? Yes, if the patient receives vein grafts. This is data from a big meta-analysis, and then you see in the right upper panel B, you see that there is of course, an improvement in patency of bypass grafts from all studies if patient receives dual antiplatelet therapy as opposed to only aspirin. And there is a further improvement possible for bypass surgery that should be taken into consideration, especially in patients with acute coronary syndrome. And this is now, once again, a subgroup analysis. And I have shown you that this could only be a hypothesis-generating trial that was published here in the journal Check, that showed that patients within the Plato study are undergoing interventions for acute coronary syndrome, and if they received CABG, that these patients had a substantial reduction in 1 year mortality from 9.7 to 4.7, so almost 50% relative risk reduction of 1 year mortality, and also almost 50% reduction of cardiac death. And this is something which could also benefit for our patients. So I would recommend, also this is a hypothesis-generating study, and now a big study, multicenter trial, the TCAP trial, is on the way that tests in elective as well as in unstable patients the value of aspirin versus ticagrelor after bypass surgery. That I would say surgery is the preferred treatment for patients with multivessel disease causing NSTEMI. If the degree of urgency does not necessitate an immediate intervention during diagnostic catheterization, I will recommend this for this patient a total arterial revascularization with 2 memories and to the left side and the radial artery to the right coronary. I think the degree of stenosis in the right coronary is high enough to justify, and I would this patient put on ticagrelor for at least 1 year after bypass surgery. I would do a pre-op CT scan of, if the time permits, of the ascending aorta, but I think he is stable enough to get a CT scan in order to assess the risk of stroke, to get with this patient to almost zero endpoint for stroke after bypass surgery. Thank you very much.
Thank you. And Dr. Ham, I think we may come back to it, but your points about subgroups are well taken. Usually people search for subgroups when the trial's negative. Dr. Ham.
Okay, again, without slides. I calculated syntax score is 15.5. So this patient is clearly below 22, and therefore I think both options are reasonable, PCI or CABG. Now, I think we have to consider that this is an emergency case. I mean, this patient has a rise or elevated troponins, so I think we have to act immediately. If I would have this case in the cath lab, I would call my surgeon to the cath lab and ask my surgeon, that's Thomas Walter, many of you know him maybe, and ask them, okay, can you take him directly to the operating room? Because that's ongoing ischemia. The culprit lesion, I think, is the LAD. And I would expect from Tommy that he says, okay, try to open up the LAD, and then I keep on doing my routine work. Most of these cases come in the middle of the night. Surgeons usually are not very happy then to take the patient immediately to the operating room. Now, this patient has a triple vessel disease, culprit lesion, I think it's the LAD, is non-diabetic. If he's diabetic, I would insist that this patient should be operated. He's non-diabetic. I think all the 3 lesions can be done, and the culprit lesion should be done immediately. I would not accept from surgical side to have this patient cool down and done over the next days, because then I would expect more myocardial damage over the next days. So something should be done immediately, and PCI can be done immediately ad hoc without taking the patient off the table. And if surgery also can be done immediately, maybe 1 or 2 hours delay, it should be done, because I would expect myocardial damage if we continue to wait in this patient. Okay, thanks. So most likely in real world, this patient would have immediate PCI.
Thank you very much. Very brief and to the point. Okay, so Philippe, what do the guidelines say? If you don't know, nobody knows.
So I've used the recommendation from the guidelines that we did in 2010. Again, we did cover in these guidelines all aspects of coronary artery disease, not only stable, but also non-STEMI and STEMI and new antiplatelet drugs. And Günther mentioned ticagrelor. Professor Ham developed and chaired the next non-STEMI guidelines that were published in 2011. That was a pure ESC guideline. So if there are some discrepancy, I'm sure we can discuss that, but I don't think so. So as I said, we use these guidelines, which were covered. So I would like to address 3 points, and most of them actually have been already addressed. The first is the Rescore. The second is the early invasive versus conservative strategy, which is a consequence of the GRACE Rescore, and Professor Ham has already insisted on that, and I think that's probably the most important point. And 3, heart team discussion also here. We don't have 2 days to think and to discuss, at least for the culprit lesion. So I think it's quite important that this GRACE Rescore, after the TIMI score has been developed, the GRACE Rescore is relatively easy for the cardiologist to calculate. You can go on the website, I think it's from UMass, for example, where you can add Killip points, the Killip class, the systolic blood pressure, the age, the creatinine, the heart rate, and the baseline risk factors, numerous things, and you get to a score. And in this case, I think the risk score of this patient is probably above 140. Is it? Do I'm correct, Chris? Did you calculate it? I think it was above 140 here. The GRACE. Yes. How much was it?
I would not expect. I can calculate it.
Okay. So the interesting point is the sigmoid curve. When you compare probability of hospital death and the risk score, you see that up to 100, the risk is very low. Starting at 150, the curves goes up, and when you have a risk score above 200 and especially 250, the probability of hospital death doing nothing, is extremely high. I come back to what you have to calculate this risk score. So it's about blood pressure, it's about age, things you cannot change. It's about heart rate. When the patient is tachycardic, it's probably because he has some form of shock. You have renal function, you have ST segment deviation, you have the markers, and so forth. So what we did in the guidelines in 2010, and it was mostly implemented and maybe even re-emphasized in the non-STEMI version of these guidelines was based on two major trials. So actually one major meta-analysis, which was a meta-analysis published in 2010 by Fox. It's about, in Keith Fox, I think it's actually from Edinburgh. It's 2010, so we just had, when we published the guidelines 4 years ago, it's from three major trials, the FRISC-2, the RITA-3, and the ICTUS trial. And you don't need a lot of time to come to see. We have patients with low risk score, intermediate risk score, and high risk score. Okay, that's the GRACE risk score. And you can see the higher you go in the risk, the higher the difference between selective invasive and routine invasive, meaning to be routinely invasive saves life.
Risk score is 111.
111, so we were below the 140, okay. And the second one is this analysis by Mehta, published in New England Journal of Medicine, early versus delayed revascularization, death, MI, and stroke at 180 days, comparison between delayed and early invasive, and you can see there is in favor of early. Well, it's not significant overall, but it is for a GRACE risk score of 140 or above. Now, Chris, if we go back to this patient, it means 115, so it means that we are here. So there is no evidence of early versus delayed invasive revascularization in this case. Okay. Now, what did we say in the guidelines? First, invasive strategy, because I think this is the most important point, is not to have this patient with non-STEMI sitting on the floor somewhere because it's Saturday morning and let's wait until it's Monday. That's when the message we wanted to give. If the GRACE score is high, or patient has recurrent symptoms or inducible ischemia at stress test, an invasive strategy is indicated, it's a 1A. And the second, an early invasive, is indicated in patient with GRACE score above 140 or multiple other high-risk criteria, meaning we should go to the cath immediately, let's say within 24 hours, even on a weekend. I think it's an important point. However, a late invasive strategy within 72 hours is indicated in patient GRACE score less than 140 or absence of multiple other high-risk criteria, but with recurrent symptoms of stress-inducible ischemia. So Chris, I assume here we are in this third line, late invasive, GRACE score less than 140, unless we consider that he has recurrent symptoms or stress-inducible ischemia. And then would you put him within 24 hours or within 74 hours in the indication of early invasive treatment?
Personally, if this patient has ongoing chest pain, then I would think that he has ongoing ischemia, is developing myocardial infarction. That's always a problem in the first hours of myocardial infarction. Of course, we don't know. So it looks from the coronary arteries, because in the GRACE risk score, you don't see the coronary.
Correct. So you should add that.
And so we saw a total occlusion, and so I think that's ongoing myocardial infarction, which is not resulting in ST elevation because he has nice collaterals from the right side.
So maybe this is not well covered here then.
Yeah, it's not really. It's not.
The presentation was one of chest pain overnight at 7, and
Because it's good collaterals.
yeah. So whether that's the culprit or whether that's a CTO that's been around a while, I'm not sure. His troponin elevation is pretty small, 0.3, so that's not consistent with an ST elevation.
Okay.
Right, it's consistent with.
But the next troponin would be more.
That was the 12 hours.
And again, as I think both of you said, we need heart team discussion in this patient. We need heart team discussion. Of course, when you go to the cath lab and you find a culprit lesion, well, the culprit lesion, we say that ad hoc PCI is potential indication. Culprit lesion in non-STEM, we are here, we say that's the LAD. We don't say that CABG is not possible. I think it should be based on a discussion between the interventional cardiologist and the cardiac surgeon, what they feel. But there is no question that this should be treated as soon as possible. This is not something where you say, well, the patient go back to his bed and then we see a few hours later. Now, revascularization at an interval, well, here, multivessel disease, but it's not stable patient, so it's really no real indication for revascularization at an interval in this case. So I think the most important thing here is the discussion within the heart team. And when we have, obviously, which I didn't mention previously, when we have a complex patient, please do consider to include other specialties in the discussion of the heart team when we have time and when it's needed. It's more a general consideration. Sometimes the GP, the nephrologist if the patient has kidney disease, the diabetologist if the patient is diabetic, the pneumologist, or the referring physician. Thank you very much.
Thank you. Yes. Can I just put a sort of slight spanner in the works? Just suppose this patient is in a community hospital which has a cath lab, and it's a very foggy day in the Western Isles, somewhere near Ullapool. And it's a long journey to Aberdeen. It's an even longer journey to Edinburgh. What would you do with a patient like that in that situation? It's difficult to transfer that patient quickly to a cardiac surgical centre. What, Dr. Laufer, what would you... Do you have centres like that in Bavaria?
No, in Austria.
Oh, in Austria, sorry.
Yes, we do.
Or in the Tyrol, then.
We do have centers that have PCI facilities, but I think they would not do it, and they would refer the patient to a tertiary care center that has.
So we keep the patient on IV medication and transfer.
I think the most important, what would be the most important argument is that the Rescore is 110. So, and if the patient has no recurrent ischemia, because as I heard, the symptoms have stopped under medical treatment, I think the intervention or the surgery could be delayed for 72 hours. That's what I would recommend in this particular case. And I don't know if it looks as if the LAD is a target lesion, and it got recently occluded, but also the circumflex has two very tight lesions with some irregularities, at least what I could see from the very brief time on the angio pictures. So I'm not sure if it is not a chronic subtotal occlusion of the LAD, but the EKG changes, I think, were over the anterior wall, right, what you reported. So I think, but if it's stabilized, I would defer it for about 72 hours. I would say it is possible to make a transportation to a higher degree center with cardiac surgery as well as very experienced PCI. And if I may comment to Dr. Hams, and that was the reason why I brought up the value of subgroup analysis, especially if they show that there is no difference. So in all the literature, in the methodological literature, it is written that you should not use this information to derive any guidelines or any substantial decisions. So if we say, well, the syntax score is 15, this is a subgroup analysis. Also, it was a pre-specified subgroup in the syntax trial, but it wouldn't mean too much for me. I know that everybody is now arguing in favor of PCI because it's equivalent to bypass surgery if it's below 22 in the low risk group. But the low risk group, nevertheless, in the syntax trial, as I mentioned, has a higher MACE rate than the group in the registry. So there is some mystery in these trials also, and it should not be overinterpreted.
Yeah. So in the UK just now, for most units, about 40% of patients undergoing CABG are in this category, presentation with acute coronary syndromes. There is no question whatsoever for those patients who are having an ST elevation MI that they go straight to PCI, that there's universal agreement on that. But I would disagree with Dr. Ham's management of this patient. He had a 3-hour episode of chest pain which is settled. The patient is now, assuming the patient's hemodynamically stable, and there is no ongoing chest pain or signs of ischemia. What we would do, and I think most units in the UK would maximise optimal medical therapy, and then, as Dr. Laufer said, operate on the patient within 3 days. And there is a period, Dr. Ham said it in a kind of pejorative way, he doesn't like cooling off. Well, any of us who operate in these patients know that there's actually quite a lot to be gained in allowing these patients to cool off. But that's very different from the patient who continues to have ongoing chest pain or ongoing signs of ischemia. There is no question they should go to the operating room. But those form a tiny majority of acute coronary syndromes if that patient is managed with optimal medical therapy. The vast majority of these patients you can get to settle down and then operate within 72 hours.
That's actually what the
Do we have the microphone?
guidelines say, 72 hours when you have a gray score below 140, say it should be done within 72 hours, right?
That's true, but yeah, I would consider this patient as an ongoing myocardial infarction, and I don't know how the next hours will be. Of course, you may be lucky that you get no further enzyme rise and things like this, but I see many patients the next day, they have enormous CK rise, and then it's too late. So I don't know how the future, I cannot predict the future in this patient. We'll maybe see in the moment, you may be lucky that you don't get an enzyme rise, but you may take down the patient in the cath lab, send him to the coronary care unit, and next day he has elevated CK, and then my surgeon say, okay, now it's myocardial infarction, I don't operate the next days or so. Because I cannot predict the future, you should go on. And all studies, I mean, syntax study is not a unstable angina or not a non-STEMI study, it's a stable angina studies. And all the studies that try to compare early against late revascularization, be it surgery or PCI, many patients are lost in the beginning because they die and only the survival of the fittest will be operated. The fittest will be operated at the very end. And since I know this, have this coronary angiogram now, and I know it's probably rather easy, I would predict as easy to open up the artery, at least I would do no harm. Why don't you open up that artery? Maybe the patient can get operated later on, but remove this part of this reason for ischemia.
Yeah, I mean, again, I would emphasize 40% of our patients fit in this category, so it's a big population and we know well their natural history. And you are right, there will be an odd one who may go on to have an infarction. But the vast majority of these patients, if managed aggressively with optimal medical therapy, assuming they do not have ongoing chest pain, no ongoing signs of ischemia, and are hemodynamically stable, the vast majority of these patients will not go on to myocardial infarction in the next 3 days. The other benefit of waiting 3 days is often when you do an echo on these patients acutely, you see anterior wall hypokinesis. Often you repeat the echo 3 days later and the anterior wall is completely normal, so that LV actually can pick up in the acute setting with aggressive optimal medical therapy.
There was a question here. Could you just pass the microphone?
I just want to make a point that we talk about 3 days, but realistically speaking, from a logistics point of view, I don't think any cardiac surgical department would be able to take on all these urgent patients and operate within 3 days. In our department, it is quite normal for patients to wait 5 to 7 days in this setting, and they wait for 5 to 7 days for their urgent in-house coronary artery surgery.
Agreed.
So is there a question here?
Yeah, and then you are out of the guidelines because we said clearly 72 hours, even with a low gray score. We have to understand that.
And maybe for the interpretation of a guideline, it says that it should be operated within 72 hours. Yeah. So you're allowed to operate the patient immediately, but it should be not later than 72 hours. That's what the guideline says. We don't know the benefit of a very early operation, but in this individual case, I would see potential benefit. If the patient has to undergo surgery, then to do it as early as possible.
There's a gentleman here who'd like to ask a question.
Yes, it is actually a comment. I assume that David, when he said optimal medical therapy, he included intra-aortic balloon pump in this, because nowadays intra-aortic balloon pumps, they have changed the practice completely, and we hardly ever have to operate in the middle of the night because of balloon pumps. So I have people staying on the balloon pump for 4 or 5 days. We haven't seen any problems with that.
Is that what you meant?
But in this category of patients, it's very unusual to even need a balloon pump if you manage them with optimal medical therapy.
I think those who are comparing
I agree with. Yeah.
Is concerned about that they may go on to develop an infarction. Balloon pumps.
Yeah, it's true that we have a lot of us have personal experience. The problem is that when you look at big trials and meta-analysis, it's deemed not to work. I mean, there is no real evidence in favor of intra-aortic balloon pump. We have had this discussion in the guidelines, so I'm not sure exactly where we will end up with that in the next version. What I want to emphasize again is about this timing, since I was involved in the 2010 guidelines. What we wanted to emphasize is the importance of an early invasive intervention for patients with Gray score over 140. That was also a very big message, because it means that for cardiologists working whoever in the world, on a Saturday morning when the patient had a Gray score over 140, he should be treated within 24 hours. That was one of the important message. It's not exactly this case because he doesn't have a higher risk score. I think that's one message we should remember. And the second is, as Chris said, within 74 hours, when the Gray score was below 140, without sign of ischemia, without chest pain or ongoing EKG signs of ischemia. These were the two important messages, but it doesn't mean that we cannot do it earlier, obviously. There is an interesting discussion between David and Chris, and I think both are complementary, actually.
Dr. Laufer, you wanted to make a comment.
Yeah, I would
And
like
then
to
Chris.
ask the panel, how would you manage the patient if there is an ad hoc PCI of the culprit lesion and the patient goes on to surgery? How would you handle the LAD 3 days later? Or if you do surgery 7 days later, in this particular case?
In our situation, if this patient did have ad hoc PCI to the culprit lesion, we would keep him in hospital for a few days, then send him home and bring him back at 6 weeks for surgery. Would be our standard practice in Oxford.
Do a lima to the LAD?
Absolutely, yes.
Okay. I think, yes, okay. Quick comment.
One more comment with respect to the Gray score. The Gray score says that the patient should have angiography within 72 hours. And this patient now had angiography, so it's a total new situation now. So the Gray score is a little bit out of business. And then I think
It's about the recommendation is also about early invasive strategies.
angiography followed by revascularization, of course. But once the patient had angiography, you have additional information, of course, that goes beyond Gray's risk score.
We've got time for one very, very quick question. Then we need to find out what really happened. Just behind you. Go back on the right.
My name is Anders Jeppsson. I'm from Gothenburg, Sweden. Actually, the guidelines are conflicting because these patients would, in Sweden at least, be treated with one of the new platelet inhibitors. And the guidelines says that we should wait 5 days to operate the patients. So, yeah, I think that's quite an important point because the risk for bleeding complications, if you take these patients acute to surgery, are very
Patient
high.
will be well marinated in clopidogrel. Yeah. Okay, thank you very much. I think we need to move on to find out what actually happened. Mark, what did you do? Then we'll tell you whether we agree.
Okay.
Oh, did the patient back?
What do you think?
So I'm not going to win any popularity contest here today. What happened was that following the angiogram, the consultant surgeon on call was called and a discussion was had. The feeling was that the LAD lesion was likely to be acute, and there were concerns that should be acted on sooner rather than later, and a decision was made to proceed to PCI. So this is the right coronary artery having been opened up, and this is the occlusion of the LAT that opened up in a pretty straightforward manner. The patient also had intervention to the circumflex. I'm afraid I don't have the post-PCI pictures for that.
And the right coronary?
So the right,
sorry.
there. So
Sorry.
so the right was open, the LAD was open, so was the circ, and a good angiographic result was had, and good resolution of the ischemia. I guess the one thing that I perhaps mention is that, whilst PCI is very good at relieving ischemia. It does seem a multivessel disease that it's not as good in terms of prognosis, which suggests to me that perhaps we put too much emphasis on ischemia. But in any case, that's what happened to the patient.
So how long ago did you do this?
So this patient, again, was 2 weeks ago. So
right.
put the cases together last week.
So we haven't got long-term follow-up yet.
We don't.
Well, thank you very much.
Did you discuss this patient with the surgeons?
Yeah, so the patient was discussed on the table with the on-call surgeon.
What time of day?
Yeah, well, this was during working hours, so yeah.
Leslie Hamilton, quick question.
Just to clarify this issue, patients had a PCI, they come back for surgery at a later stage. What do you do with the dual antiplatelet therapy? The cardiologist don't want you to stop. When they come to surgery, at an interval, whatever we can debate the interval, but what do you do with the dual antiplatelet therapy?
Quite often in this situation, what our cardiologists will do, in anticipation that they believe the patient will require surgery, they use a bare metal stent, where they appreciate that this patient is at high risk for coming back for surgery. If the patient is on dual antiplatelet medication, being aspirin and clopidogrel with a drug-eluting stent, I would not stop either of these. I'd be quite happy to operate on that patient. It's very different operating on that than from a patient on ticagrelor or prasugrel, because there's a very big difference.
One more question, and then we'll go to David Taggart.
I don't have a question. I just want to make a point.
Comment.
Leslie, in our practice, routinely in patients who are on dual antiplatelet therapy, we do not stop aspirin or clopidogrel. Patients who come even for elective coronary artery surgery, we just let those drugs be on. It makes no difference.
That's why we're here. David.
Okay, thank you. So I've been asked to sum up this session, so I've listened to some expert presentations. I've listened to all the evidence very carefully. I've tried to weigh it up and evaluate it as objectively as I can. And I can say the take-home message is CABG is best for everything. So on a slightly more serious note, what did we discuss today? Well, we first discussed the treatment options for osteal LAD disease isolated. We came to the conclusion that probably both PCI and CABG are both good treatments for this. In a surgical group, we favoured the long-term benefits of mammary artery, but we did not say patients should not be offered the option of stenting. And the key point we made was that patients must be given proper choices and involved in the discussion. When we came to the case of multivessel disease, this was a bit more complex. We covered a couple of issues here. First is, none of the surgeons knew what the syntax score was. So if the cardiologist says, the syntax score is 19, what he's implying is there's no difference in survival benefit between CABG and PCI. But if you're at an MDT and you say, well, I disagree, I think it's 27, everyone sits there and doesn't know what to do. But it's very important to know what the syntax score is, because in the lower cohort, and this is notwithstanding cautions about interpretation of subgroups, we know that if you have an intermediate syntax score, at 5 years you have an absolute survival benefit of 7 percentage points, accompanied by a very marked reduction in the incidence of myocardial infarction and repeat revascularization. If you're in the higher syntax score group, you have an absolute difference in 9 percentage points at 5 years. And should we believe what syntax is telling us? Yes, we should, because there are now 13 propensity match registries with over 430,000 patients comparing outcomes between PCI and CABG. The survival advantage for CABG appears at 3 years, but it continues to diverge past 5 years. So syntax is essentially telling us the same story that we've seen from registries of propensity match patients for the last decade. The other point that was brought out, however, important in the acute coronary syndrome setting is to know how invasive to be and how quickly. So we've heard how important it is to decide when you need to be invasive rapidly if the patient has a high GRACE score. And then we decided if the patient does have multivessel disease, what do we do? And again, it really does come back to having some understanding of the syntax score. There is no question that for most of these patients, PCI in the acute setting will bail the patient out. But we can also offer a therapy which guarantees outcomes to that patient over the next 10, 15 and 20 years. And it's very important patients are given these options. The final thing we discussed was the timing of surgery. Philip made the point that the guidelines say that these acute patients, if they are going to be operated, should be done within 3 days. And most of us will aim for that. But as Vipin Zamfar said, in the UK setting, these patients will, because of the logistics of our system, with no spare capacity, will often wait 5 to 7 days. And the final point we made was what medication should we keep these patients on if you're operating them in the acute setting? I no longer worry about patients on aspirin and clopidogrel, because when you get used to it, the number, in my experience, who bleed badly with that combination is relatively low. But I think patients on both ticagrelor and prasugrel are a totally different story, and we will make every effort not to operate for 5 days in those patients. So on that point, I'm going to conclude by summing up. Thank you.
Any other questions or comments? Well, it just remains for me to thank my co-chairs and particularly to thank our invited speakers and to thank the audience. Thank you very much.
Time for a quick coffee?
That was a good session.
It was excellent.